Good afternoon, viewers. Today, I want to discuss some burning aspects of prenatal ultrasound, which helps to optimize the pregnancy outcome. But before that, I would like to introduce myself. I am Dr. Khurshid Alam, lead fetal medicine consultant in Fitomat Foundation, Kolkata. Now you will be wondering, what is this fetal medicine? Fetal medicine is basically a science which deals predominantly with the fetal health and also maternal health to some extent. Now, before plunging into the topic, to make it more interesting, I have tried to basically clear 5 misconceptions which a pregnant woman have in their prenatal ultrasound. When they undergo ultrasound, they have some intriguing questions in their mind, and I would like to clarify at least 5 of them. There are many more, but at least the major 5 of them. First question which the pregnant woman encounters in their mind is that they feel when their parents planned the pregnancy, they did not go any ultrasound and still she is fit and fine. So that was the time of non-ultrasound culture. Now, why do we emphasize so much on getting ultrasound done so often? The reality is science keeps changing, so is the knowledge, and hence with advent of ultrasound and improved resolution, we have so many more advantages. Like, for example, a pregnant woman, when she is tested positive on her pregnancy kit, the first thing or the reflex action is she reports to her referring doctor, and he or she sends her immediately for scan. And why is this scan important? Number one, to understand whether it is a real pregnancy or it is a biochemical or a pseudo pregnancy. And once you confirm, yes, it's a real pregnancy means the gestational sac is intra-endometrium, is within the endometrial lining. And once you confirm it is in its normal location, next thing which comes into mind, whether it is a single pregnancy or a multiple pregnancy. And after clarifying that, next question comes whether it is a viable or a non-viable pregnancy, which is determined by looking at the heartbeat. So once you have clarified that yes, it's a normal intrauterine pregnancy, single or twin, and it is a viable pregnancy, it immediately gives an immense sense of reassurance and happiness to the pregnant woman, and she feels yes, she is in right pathway for this journey of pregnancy, which is so very precious for her. After that, we start with dating her pregnancy. That means what is the exact gestational age, because she may not remember her LMP, or there might be irregular periods, or she was on contraception, or she may be lactating her previous child. That means she was in lactational amenorrhea, where she is not very sure of her dates. So we can help her by ultrasound methodology to determine the exact gestational age in case there is any discordance. And also, this gives her the first exposure to see her fetus, to see her embryo in front of her on the screen. And you will agree with me that there is no more pleasure or satisfaction than to see your baby in front of you on the screen for the first time. So this creates a lot of sense of awareness and responsibility in the pregnant woman. This was the first doubt I wanted to clear, the misconception. The second misconception which we face in day-to-day practice is that why do we ask for so many scans? So what is this fuss about so many scans and so many visits which we are time and again telling them to come for? The simple reason is different scans at different period of time have got different values. They are all complementary and they add different values at different period of time. For example, when she comes for viability, as I have already discussed, we see for the location, we look for the heartbeat, number of the pregnancies. But after this, when we call at first for the first trimester scan between a window period of 12 to 14 weeks, at that point of time, we look into the structure of the fetus more in detail, and also there is an extensive checklist as given by the International Society of Ultrasound in Obstetric and Gynecology, which gives us a detailed checklist, and we undergo through that checklist very meticulously to stamp that yes, this fetus is structurally normal for this period of gestation. And in that process, we do another thing, that is, we take some parameter like nuchal translucency, crown rump length, we see nasal bone, tricuspid regurgitation, and ductus venosus, which helps us to screen for certain aneuploidy or the chromosomal abnormality. And the most common aneuploidy is trisomy 21. So it serves as a dual purpose. Number one, to establish structural normalcy, and number two, to establish that yes, she is not at high risk for the aneuploidy. And together we call it a combined first trimester screening, where we give her blood for a biochemical screening, and the software algorithm integrates both the components and give us a meaningful risk for the Down syndrome screening. So this is a very important process, and if it is twins, it helps us to establish whether it is an identical twin or non-identical twin in a layman language. In our language, what it is important is to look for the chorionicity. If it is identical twin, it is called a monochorionic twins, and if it is non-identical, they are referred to as dichorionic twins. And now with advent of newer machines, the resolution and growing knowledge in the field of fetal medicine, the entire pyramid of care is inverted. That means the most emphasis is given in the early scans, because we want to rule out any major structural abnormality as early as possible, and as we go down, the number of scans reduces. So this was the second misconception I have cleared. The third misconception is every pregnant woman, or if not every, most of them, they feel the pregnancy is of 9 months, and they calculate 9 into 4 is equals to 36 weeks. So once they are nearing 36 weeks, they feel they are at the end of the journey. But this is a very big misconception, because pregnancy is of actually 40 weeks. That equates to 280 days. So the emphasis should be to continue the pregnancy at least close to 39 weeks to get the baby additional maturity. And if you deliver before 37 weeks, it is called a preterm birth. And you don't want your child to be weak because of the preterm birth. So this is a very important misconception which needs to be cleared. And also, if there is wrong dates, like they have not come to you before, they have come to you at a later on in the gestation, and your ultrasound biometrics, that means when you are measuring the head, abdomen, femur length, and you get a corresponding gestational age, and those are not matching with the age of the fetus, in those cases you have the method to change the dates and know exactly what is the gestational age based on which delivery decision can be taken. So this was a third misconception. Now the fourth misconception, that there is a sense of anxiety in the pregnant woman, that when we are doing so many scans, is this safe for the fetus, or there might be some side effects because of ultrasound? So let me clarify this for you. Ultrasound is a modality which deals with non-ionizing radiation. That means there is no harmful radiation which is emitted while doing the ultrasound which will harm the fetus or the mother or the operator. So it is completely safe for the fetus, even if we do it in some occasions very frequently or alternate days also, it is not at all going to harm the fetus in any way. And also, we must take care of inadvertent usage of Dopplers, because Dopplers gives little bit of increased energy. So, especially in early pregnancy, when we are doing the viability scan, it is recommended not to use the Doppler, and we take all safety precautions as per the principles of ALARA. ALARA stands for as low as reasonably achievable. And there is also a misconception when they undergo scan that whether nuchal cord around the neck is there or not. So it is very important to understand at this point of time that cord around neck is not at all a lethal problem. It is not at all a cause of concern, because most of the time they are free floating, they are dynamic in nature, they come around the neck and they move out as well. There are very few chances that it will be very tight and it will strangulate the fetus. So you don't have to unnecessarily worry about the cords, nuchal cord. Yes, it may be a good practice to see, but once you see that, it's a good practice to counsel the patient that this is not something of concern, and just you can put her on follow-up like any other normal pregnancy. The fifth misconception is, if there is growth related issue in the fetus, like you are serially monitoring that fetus and you realize as it goes in the third trimester, it is not maintaining its growth trajectory. In those cases, they feel if they deliver it out early, this baby can be managed outside in a better way and it will be a safer option. But this is again not correct, because the longer baby stays inside the mother's womb, more maturity it gets. So there is a dictum, when in doubt, don't take the baby out. But you must have certain tools to ascertain the safety when you are prolonging the pregnancy in case of growth restriction. And that Doppler tool is called, Doppler, color Doppler. This color Doppler can be used to risk stratify whether it is safe to continue the pregnancy or we need to terminate this pregnancy. So this gives us a pathway of care and also helps us for the surveillance, like at what interval we need to call these patients. So this guideline is given very much with this color Doppler ultrasound. Now I have cleared the 5 misconceptions, but there are something more which I want to discuss with you, that this was all related to the diagnostic aspect of ultrasound in pregnancy. But apart from the diagnostic ultrasound, which looks at the structural normalcy of the fetus, which looks at the growth, which looks detail into the fetal heart in the form of fetal echocardiography, it looks detail into the fetal brain, which is called neurosonogram. Apart from all these diagnostic aspects, it has got a very pertinent role in the therapeutic options also. And this therapeutic aspect of the ultrasound is growing in popularity day after day. Like, for example, if when we are screening the woman, we found that she is in high risk category for Down syndrome, or the fetus is having certain structural problem, the next thing which we want to clarify is whether this baby is really having that genetic problem for which it is showing high risk, or there is something else. And to clarify that, we have to do diagnostic amniocentesis or chorionic villus sampling. And once we do that, we take out the sample. When we are doing amniocentesis, we take out amniotic fluid, which is done between the window period of 15 to 20 weeks, and that fluid is sent to lab, and several genetic tests can happen on that to give us the answer. And if it happens early, like in a window period of 12 to 14 weeks, then the procedure which is done is called chorionic villus sampling, where we take tissue sample from the placenta and send it for testing. So this is a very beneficial tool which gives us not only information about the structure of the fetus, but also about the genetic makeup of the fetus. And now at Fetomat, we are also expanding to many more sophisticated therapeutic procedures like fetal laser, shunt placement, bipolar cord occlusions, radiofrequency ablations, which are done in selective cases of complications of monochorionic twins. So far, we have done few cases with success, and we have successfully launched our therapeutic venture also as far as fetal medicine is concerned. Thank you so much for this patient hearing.